Hello everyone, my name is David Hsia. I'm at Harbor-UCLA Medical Center, and I would like to thank the CTS for the kind invitation to talk to you today about advances that we have in the fields of the diagnostic approach to lung cancer, including tumor markers, genomics, and liquid biopsy. Before we start, I have no conflicts of interest to disclose. I'm going to start off with this image because I think this is an image very familiar to all of us. We may have a patient with a lung lesion of unclear significance, and the algorithm that we go through is we may have to determine if they have a low probability for lung cancer. We may feel comfortable performing serial CT and having a relatively non-invasive follow-up approach. For those with high probability lung cancer, we may send them empirically for surgical resection. But for those patients who are intermediate probability, perhaps we'll perform bronchoscopy or ask for a transthoracic needle aspiration. But the difficulty that we have is that the sensitivity is sometimes less than ideal, and both of these are potential for complications. So now the difficulty comes into play, which is how do we go through this difficult decision-making process? And I think this is one that is very familiar to all of us as pulmonologists. There are really three different aspects to this problem. One is going to be lesion identification. The second one is going to be risk assessment. And lastly, tissue diagnosis and adequacy. So what we're going to talk about today are going to be different advances in the area of risk assessment and diagnosis and tissue adequacy. And you can see that there's a large number of topics that we're going to try to cover today. So we're going to have to cover them very broadly. I'm going to start off with risk prediction models because this is something that we use in our clinical practice all the time. You may use the Mayo model or the Brock model or the VA model, but I think one of the important things for us to understand as clinicians is how do our tools work in real life? One of the greatest criticisms is that many of these models were validated in patient populations that had very high risks for malignancy. That doesn't always describe the patients that we are seeing in our clinics. So this is a relatively recent study that I wanted to draw to your attention where they looked at 8 different prediction models, and they looked at them in lung cancer screening populations, which the prevalence of lung cancer was not as high. And how did they perform? This is very busy, but what you can see is that on this graph, the top 4 or best performing prediction models were what's known as the Pan-Canadian model. These outperformed the Mayo model or the VA model. And the Pan-Canadian models may be more familiar to you as the Brock model, and there's several different iterations of it as to which pieces of information are input into the model. But you can see that they performed the best. And I think this is really important for us to understand. So therefore, we realize that in a lower prevalence population, perhaps not all of these prediction models perform the same. But moving past just prediction models, one of the difficulties that we have is that there's a certain degree of subjectivity that goes into these models. Where exactly do we draw or measure the diameters of some of these lesions? So there's the problem that we have that there is inter-interpreter or inter-reader variability. 2 different radiologists or pulmonologists may measure and read these lung nodules as different sizes. And in addition, between one CT scan to another, exactly how that 3-dimensional lesion is cut may also affect our measurements. So is there a way that we can move away from some of the inherent subjectivity that we see in measuring lung lesions? So this is where the field of radiomics, I think, is very exciting. Radiomics is looking at machine-measured variables. And I think one of the easiest one for us to wrap our head around is something like volumetrics. Because I think we all recognize that one of the limitations is that when we try to characterize a 3-dimensional lesion with a 2-dimensional measurement, sometimes even just a 1-dimensional measurement, we will be told that a lung lesion is, for example, 2.3 centimeters. But that doesn't describe the rest of the lesion. So newer software are able to measure different aspects of these lesions and find very small, minute changes that may not be readily seen by the naked eye. So volumetrics, as an example, it can then calculate the exact shape and volume of a 3-dimensional lesion and then identify if there have been small, subtle changes either with growth or shrinkage in these lung nodules, and this may help us remove some of that subjectivity. Moving one step further beyond just radiomics is the concept of machine learning, which I think is very exciting, because what we can then do is feed not just the CT scan data into a computer software system, we can also feed a training algorithm of what the outcomes were. Were those lesions benign? Were they malignant? And by doing so, the computer then can learn and develop algorithms or regression models as to what characteristics of these lesions were most associated with the outcome measure of either malignancy or benign lung lesions. Now, deep learning is a subset of lung nodule assessment of machine learning that is beyond my capability of adequately describing, but this is where where people can create neural networks from computers, and they can then learn based on the input that as they see more and more cases that are fed to it, it can then learn what the outcomes are and then come up with better ways of predicting whether or not a lung nodule is malignant or not. And I think this is going to be a very exciting emerging area of lung nodule assessment. So let's move to something that is currently available. This is in the area of genomics and proteomics. This is a test that, or a study that came out in 2015 that I had the fortunate chance to be a very small part of this trial. But this was a genomic trial, and let me just walk you through what was performed. We had patients who were designated already to undergo bronchoscopy, and we would have a pre-test probability of whether or not they were high risk, medium risk, or low risk for cancer. Now, the idea of genomics is that if you have a lung nodule that perhaps is malignant, you may have downstream more proximal changes in the airway genome that can be reflected. So if you can collect samples from perhaps the large mainstem bronchi that are not related to the lesion, but they may reflect some of the genomic changes that would reflect whether or not the peripheral lesion has cancer or not. So we perform bronchoscopy, and before even doing your navigation and biopsies, we would then brush the large airways, send those cytology brushes off for RNA evaluation. And based on these data, a genomic classifier was generated. And to cut to the chase, the combination of the genomic classifier with bronchoscopy together, those two had a sensitivity of around 96 to 98%. And had a very high negative predictive value of 91%. So how does this work? Since it has a high negative predictive value, it's not very good necessarily at telling you who has cancer, but it can tell you who may not have cancer. So what you end up with is a graph like this, where you have a pre-test probability on the x-axis, and on the y-axis you have the post-test probability. Now, the idea is that if you have a patient with a pretest probability, in this case, the example is drawn at 66%, where that solid line is, with a negative bronchoscopy and a negative genomic classifier, you may have a decreased post-test probability, in this example, of maybe 10%. Hopefully, if you can decrease the post-test probability enough that perhaps you as a clinician and in conjunction with your patient, your medical decision-making may feel more comfortable with moving away from an aggressive follow-up plan, and perhaps you'll feel comfortable with just having a less aggressive approach, perhaps with serial CTs. So how would you use this in real life? What we would do is you would identify patients who you would perform bronchoscopy on. You would collect your brushing samples of the large airways at the beginning of the study and then send those off to the lab. You then perform your bronchoscopy biopsies as you typically would. If your bronchoscopy comes back and it is diagnostic, you're done. You have your answer. If they come back and they're non-diagnostic, you then request that the genomic classifier is sent on the cytology brush specimens, and you'll get a report that looks like this. Now, what you hope for is that in a small subset of patients, you may have a patient who started out as intermediate risk. But with the negative genomic classifier, you can then down-classify their post-test risk. And if you can down-classify them enough that your medical decision-making feels comfortable that with a negative bronchoscopy and a negative genomic classifier, perhaps you don't need to escalate for repeat invasive testing, even though your bronchoscopy was negative, then perhaps you might feel more comfortable just doing something like serial CTs. So how does this perform in real life? These are two different studies that have looked at this, and I want to focus your attention on the right-hand column. This is a study that was just published. It was a registry, a prospective registry from 35 different centers, and they looked at 283 low to intermediate risk bronchoscopy patients who had non-diagnostic procedures. Of that category, about a third, 34% of them, had a negative genomic classifier, which then down-classified their post-test risk for malignancy. And of that subset, almost 3/4 of them had a change in their management plan from a planned invasive follow-up procedure, such as a transthoracic needle or maybe surgery, and they were able to feel comfortable performing just surveillance monitoring. And I think where this becomes important is this may help us identify those patients that perhaps we don't have to escalate our follow-up plan. Now, along similar lines is this study. This is a proteomic study coming from plasma proteins. So this is a blood test. And they looked at 685 patients with intermediate risk lung nodules. And they looked for these two different plasma proteins. And what they were able to show was that this proteomic biomarker had a sensitivity of 97%. And as a result, had a very high negative predictive value of 98%. Specificity was not very good. But very similar to the prior study that I showed you with the genomic classifier, the utility of this is that it is very good at ruling out those who may not have cancer, not very good at ruling those who may have cancer. And you can see these AUC curves on the right-hand side, that the curve in red, the integrated classifier, the proteomic study, in addition to all the other tools and clinical assessments that we have at our disposal, performed the best. So how might this work? When you send this study off, this plasma protein or blood test off, you may have a patient who has intermediate risk probability for malignancy, and in a certain subset of patients who have a negative proteomic biomarker profile, you may be able to downgrade their post-test probability to a low risk, therefore making you more comfortable to say, perhaps this is not a nodule that I need to investigate with an invasive procedure such as a bronchoscopy or a transthoracic needle aspiration or surgery. And that would be the ideal scenarios to identify that subset. So now we're going to move over to this far right-hand box for diagnosis and tissue adequacy and some of the advances that are coming out with bronchoscopy as well as tissue assessment. So the problem that we often have is when we talk to our colleagues who don't perform bronchoscopy, they think of it as a singular test. I send off a test, I have a certain sensitivity, and I get an answer. But for those of us who perform bronchoscopy, I think we realize that no two patients are the same. There are procedural variables, patient variables, physician variables as to why you may have different diagnostic yields or sensitivities for malignancy. In addition, there's multiple different steps. I may fail at navigating to the lesion, or I may be successful at navigating, but I just can't obtain the tissue. Or I may even be able to obtain tissue, but I can't get enough of it. These are problems that plague us. Some of the problems have been overcome with some of the newer navigation systems and radial EBUS as an example, but we still have difficulties with some of these that I've highlighted for you, such as lesions that may be at an angle or not immediately adjacent to an airway. If you have a number of different turns, you may navigate but still have difficulty with tissue acquisition, as I'll show you. And then there's also this entity known as CT to body divergence that we'll discuss as well. Some of the newer advances in bronchoscopy hopefully will help us overcome some of these. So this is a problem that we often encounter. This is a CT scan, and you can see that the arrows show you that there are two different airways. On one airway, you will have a radial EBUS image that demonstrates that you are right in the middle of the lesion. However, a different airway shows you that the lesion is off to the side, or what we'll refer to as an eccentric lesion. This becomes a problem because this in and of itself decreases your diagnostic yield by about 50%. And that's significant. So we will do our best to try to find an airway that gives us a concentric view. but sometimes we just can't find it. What this represents is that the lesion is off to the side. Now, is there a way that we can angle our diagnostic tools to be able to biopsy it? And in addition, one of the other problems is, what if the lesion is just a little bit outside the airway? We have traditionally been beholden to the airway. We are stuck in the airway. So can we get through that airway wall? There are newer tools that are coming out and emerging that I think are going to change our ability to get to these types of lesions, where traditionally we can navigate close to them but not be quite there. So this is a tool known as the cross-country tool. This is a navigation tool, but there are several different variations that are being developed that allow us to penetrate through the airway wall and then travel a short distance and biopsy a lesion. And I think this is going to be a very important tool for this type of problem. Now, in addition, we sometimes have other limitations to flexible bronchoscopy. On the fluoroscopy image on the left, you can see that the bronchoscope has been fully advanced, and as you try to advance the bronchoscope further past the wedge position, the bronchoscope will coil because it doesn't have rigidity all the way throughout it. If you were able to find a bronchoscope that can maintain a certain degree of stiffness all the way through, you may be able to advance or navigate further. In addition, that stiffness becomes important because, as you'll see on the right, this is a fluoroscopy image of a guide sheath that has a curve at the end. Now that curve becomes very helpful because that helps us direct the catheter where we need to go. But sometimes we are pointed in the direction that we want to be, but with the advancement of our diagnostic biopsy tools, we deflect the catheter and we no longer are pointed where we would like to be. So having a degree or being able to control that stiffness becomes important. So there are new robotic systems that are coming out, and these are two different commercially available platforms. And what I wanted to point out to you is that there's a large commitment of space, personnel, and capital resources for these. But some of the advantages that they bring to the table, we'll highlight them here. Number one, you'll see on the image on the far left. You'll be remotely controlling it, almost like a video game. But these will allow you to maintain a certain degree of stiffness in the catheter. And this becomes important because it allows us to administer a greater deal of force at the distal tip and potentially navigate further. So you can see at this video image in the middle, you can see just how many generations of airways that you can traverse where a traditional bronchoscope cannot be navigated that far. In addition, these robotic bronchoscopes are thinner. And so as a result, they can get farther out in the airways as well. And you can realize this bronchoscope is still being navigated further and further and further. This is quite impressive. What you're going to see on fluoroscopy images here in a second is just how far out they were able to navigate. They were able to navigate this bronchoscope system, this robotic system, almost out to the periphery. Now the question comes out, what if once you navigate out there, the lesion is off to the side just a little bit? Do you have control of being able to adjust that tip and not be deflected when you pass your forceps or biopsy needles? And here's a video example on the right where you can see just how fine that control is of that distal tip. And this really allows us to target the lesions that we could traditionally get close to, but may not be able to successfully biopsy. Now, another issue that we run into is confirmation that in real time we have reached the lesion in question. One of the difficulties is that we have this issue known as CT to body divergence. Most of our navigation platforms are based on a CT scan that may have been performed several weeks prior, and on top of that, it's a static image, where in real life we know patients, they breathe, their lungs move, the diaphragm moves, and the heart even beats and changes the shape of the lungs or where the nodule may be. So we may think that we've successfully navigated to where we think on the static image the lesion happens to be, but we may not actually be there. Now, the problem with fluoroscopy for some of these small lesions, as you can see on the top left, is that sometimes these small lesions are not readily apparent on fluoroscopy. Some newer software has been developed that you can now change the angle of your C-arm and take multiple different images, and all of that data is then fed into a software system where then it can identify where that lung lesion is, and you can see how that same lung nodule is now readily apparent. It has now turned the invisible into something that is radio opaque. That information can then be fed into your navigation system to help guide you as to where you need to biopsy or where your catheter is relative to that lung nodule that is being identified on that fluoroscopy. Along similar lines, there's a concept of cone beam CT, and it's not a small piece of equipment. It's also a big investment of capital equipment as well as space and resources. But it differs a little bit from fan beam or spiral CT, which we're probably more familiar with. But what it allows us to do is it provides us real-time imaging adjunct in the operating room or the bronchoscopy suite. So this is an example of a CT scan, and I think you can see from that red arrow, most of us would appreciate that that is a small lesion. That would be very hard to reach with a bronchoscope and also hard to identify where it is located. However, you can take cone beam CT images and take that data and feed it into through a software system in conjunction with your fluoroscopy. And so this is known as augmented fluoroscopy. And you can see on this fluoroscope image that with conjunction with cone beam CT, it's now identified where that lesion is as indicated by that little blue object or nodule. And therefore, you can now use real-time fluoroscopy to demonstrate that your bronchoscope and guide sheath have successfully been navigated to that lesion. And here you can see a biopsy needle being advanced. And you can even see that there's been a slight deflection with your biopsy forceps when you advance that through the catheter. Now, in addition, cone beam can be used by itself just to provide real-time confirmation that your catheter is truly in the lesion in question. So here you can see an image where you see the cone beam CT images on the bottom and the yellow arrows demonstrating that that white appearing catheter has truly been successfully navigated to the small lesion in question. Now you may say, don't we already have tools that can do this? Doesn't Radiomics do this already? And the answer is it does. It's a wonderful tool and it's very valuable, but the hard part is sometimes we are still limited by Radiomics. And these are two examples. So on the top, or both of these Radiomics images, if you're familiar with Radiomics, look very promising. But on the top right, you can see that the little arrow shows you that you're actually navigated eccentric or adjacent to the nodule in question. So this again will decrease your diagnostic yield by about half, and that's a problem. Now the bottom image is even worse. The Radiomics image may look promising, but you can see by the associated cone beam CT image that your catheter is actually adjacent to atelectasis. Now, one of the problems that we have is that we do a lot of these navigation bronchoscopies with the patient fully sedated with general anesthesia and intubated or maybe under MAC anesthesia in the operating room or in the endoscopy suite. They often will develop atelectasis, and this is not appreciated. And so therefore, the problem with CT to body divergence, we may not realize that we navigated to the wrong place, and Radiomics may not be able to confirm for us that we truly have successfully navigated or not. So this is a role that I think is emerging for cone beam CT. Now, how well all of these different advances will perform in improving our diagnostic yields, we still have yet to see. This data is emerging. But again, I think these are some exciting areas that are being developed in our ability to biopsy some of these traditionally hard to reach lesions. So now I want to shift gears over to molecular markers and liquid biopsy. This is just a cartoon showing you over the last 20 years or so. I think all of us in this space will recognize the importance that molecular markers have had on thoracic oncology. Now, this is an algorithm from the NCCN guidelines, and this is probably something that we're also very familiar with. When we look at advanced or metastatic non-small cell lung cancer, who should we send molecular markers on? So we will often think of them as two different categories, squamous cell carcinoma and the non-squamous cell, non-small cell lung cancer population. Both categories, as indicated in green, we should be sending PDL-1. Now for the non-squamous non-small cell lung cancer, we should be reflexively sending a panel of markers for things such as EGFR, ALK mutations, ROS1, BRAF, so on and so forth. However, you can see in red that for squamous cell carcinoma, the guidelines suggest that you should consider sending them. And we'll talk a little bit about the reason why. So first of all, with regards to guideline recommended testing, this should be done as part of a broad profile assessment. Second generation testing is broad profile assessment. Sometimes you may hear it referred to as next generation sequencing or massive parallel sequencing. And that's because the first generation testing used to test individual mutations. And we would test it based on the concept of mutual exclusivity. That if you were positive for one, such as EGFR, it is highly unlikely that you would be positive for any of the other mutation markers. So we would do this serially, and if one came back positive, we would then stop our testing. If one came back negative, we would then move on to the next marker. But this takes time. So we should be doing it all as part of a single test broad profile assessment. Why might we consider, but not reflexively send it off for squamous cell carcinoma? And that's because there's a much lower association or prevalence of these molecular markers in squamous cell carcinoma, less than 3 to 5%. However, when might you consider sending it? Remember that there's always the risk of sampling error for heterogeneous tumors when we have small specimens. And over 70% of lung cancers are diagnosed by bronchoscopy or cytology from pleural fluid. Those are considered small specimens. And this is the problem. You can have patients who have mixed tumor types. So you can easily see how you might accidentally biopsy a component that is squamous cell carcinoma, but it doesn't, the pathology doesn't reflect the fact that the patient has adenocarcinoma and may have driver mutations where they might benefit from treatment with some of our newer TKI therapies. So who might we consider this in? If you end up with squamous cell carcinoma in patients who perhaps have a profile that would suggest that perhaps they have a higher prevalence of driver marker mutations. So those would be patients who might be younger, maybe female, non-smokers or light smokers, and even some ethnic groups are associated with some of these molecular marker mutations. If you find them and they have squamous cell carcinoma, you may still consider sending off broad profile testing for driver mutations. So how well do we do with detecting these driver mutations? The upper box in green shows you that patients who have lung biopsies, lymph node biopsies, or pleural biopsies, not pleural fluid, but pleural biopsies, they traditionally have very high sensitivity for molecular marker testing, such as EGFR and ALK and PD-L1. Where we've often had difficulty are specimens that have lower cellularity, so things like BALs or pleural fluid. Now, our first generation testing performed very poorly with these types of specimens. Our newer generation, our next generation sequencing, the results are much more encouraging. The data that I'm showing you here in the red box, this is from a pleural fluid study out of Duke, where they used a panel of EGFR, KRAS, BRAF, and ALK, and they showed that with next generation sequencing, they had around a 71% adequacy for this entire panel. And that's much better than the performance characteristics of the first generation testing. So this is encouraging that we're advancing in our ability to detect some of these driver mutations. Now this brings us to the last topic, which is liquid biopsy. So the idea behind liquid biopsy is sometimes tumors may either have necrosis or apoptosis, and either cellular material or just genetic material is available in the bloodstream. Can we detect that through a simple blood test? And that's what a liquid biopsy is. So just to walk you through some of the numbers of how well liquid biopsies are currently performing, this is a meta-analysis looking for driver mutations in blood samples for EGFR. Now, studies are still relatively small at this point in time, but overall the sensitivity was suggestive of around 66%. Not that great, but pretty good. And the specificity was around 95%, significantly higher. So what this tells us is that if you identify with a liquid biopsy that the patient has a specific biomarker, it becomes actionable. It is a high specificity test. You can now use that information. However, if you don't find it, it doesn't mean that it doesn't exist. it may be that your sensitivity is not high enough and you have a false negative. In addition, there are a number of different commercially available platforms that are out there, and they test for a variety of different numbers of mutations. And you really need to know what your assay tests for so you know what you're looking at and what information you're getting. Now, on top of that, the performance characteristics of these tests may vary. Now, this is data from a prostate cancer study using liquid biopsies or blood tests using two different commercially available tests for circulating free DNA. But what you can see from this graph is that the congruence from these blood samples that were identical samples were not completely 100%. So I think one of the things that is a take-home message from this is that there may be variability in the sensitivity of the assays that we are using out there. So what are some of the general principles for liquid biopsy? Number one is that histological tissue is still the preferred diagnostic method. Number two, there are currently no analytic performance standards for testing, though hopefully those will be emerging. The third issue is that most of these liquid biopsies have very high specificities. They are actionable if we find something, but they may have high false negative rates. So remember that when you're assessing your patients. When might we use a liquid biopsy? So first, if a patient is medically unable or unfit to undergo invasive tissue sampling, a liquid biopsy might be helpful. Also, perhaps we get a biopsy where we show a diagnosis of cancer, but insufficient tissue for adequate molecular marker testing. And on top of that, if obtaining more tissue is difficult, this is where a liquid biopsy has a valuable role. So this sort of concludes the different advances that I wanted to discuss with you today. And I hope you realize and are as excited as I am about some of the new emerging diagnostic approaches to lung cancer that will hopefully change our clinical management in the upcoming years. So with that, I'll go ahead and conclude, and thank you very much for your time and attention.